of Sustainable Healthcare Foundation. He's a medical doctor with an MBA and over 10 years experience in the healthcare industry, and having had leadership positions in Massachusetts General Hospital and leadership and management training at the University of Washington. So welcome, Dr. Walter Obita. We also have with us Dr. Kibacho, Joseph Kibacho. He is the head of the Division of Non-Communicable Diseases in the Ministry of Health in Kenya. And he's a medical doctor with public health training from the London School of Hygiene and Tropical Medicine in the field of epidemiology. His keen focus is on integration of NCDs in the primary healthcare platform. Thirdly, we have with us Faith Muigai is a professional, is a health professional with over 20 years in local and international health and working in both public and private sectors. She's currently the regional director of Safe Care Program with Farm Access Foundation here in Kenya and implementing in Africa. She has served as the Chief Medical Officer of Jacaranda Health, and she has quite a huge experience in the area of QI, quality improvement in health. And so with our panelists here today, we're going to discuss PPPs. And as we know, public-private partnerships have been in discussion for the last 20 years as a huge, having huge potential to achieving universal health coverage. And really it involves the partnership between the public sector and private, bringing together their strengths to synergize and deliver on different aspects of the health agenda. And so during this webinar, I want to understand, what's the experience in the private sector, in the public sector. Do we really believe that PPPs could actually help us achieve UHC? And we'd like to also know what are the good examples that are out there that we can learn from and what we need to improve. Or do we want to say maybe we should think twice about PPPs? And so to start us off, I'd like to pose a question to Dr. Walter and ask, what's the role of the private sector in PPPs in healthcare to achieve UHC?
All right, thank you, Phasia, and welcome to all the participants of this webinar. So the role of private sector in PPPs is essentially to provide a model for funding or providing a service for the public infrastructure or service delivery projects. In terms of health, it's either infrastructure in health or service delivery in health. And there are various ways that the private sector can be able to do this, and it's based on the various options of PPPs. If it's in infrastructure development, you can do design and build finance, operate PPPs. You can do build, own, operate PPPs, or what we call BOOs. You can do build, own, operate, and then transfer back to the public system. That's BOOT. You can buy, build, and operate as a form of a PPP. And then there's also build, lease, operate, and then transfer. When it comes to service delivery options, you can get an operation license as a form of a PPP. You can do operation and maintenance contracts as form of PPPs. Or in just some cases, you can decide that you only want to do financing, where you have the private sector partner just provide the financial services and fund either the service or the infrastructure that is to be operated.
All right. Thank you, Dr. Walter. And now to the public sector, as we, lay the grounds for this conversation. Dr. Kibacho, would you tell us what do you think is the role of the public sector in PPPs?
Thank you, Dr. Karua. I hope you can hear me. I'm in a noisy restaurant, so I hope you can catch me. Okay, thank you. It's interesting to pick up from where Walter has enumerated the roles and the options of public-private partnerships. And the classical definition starts with the public, actually, because the public is the one that has the legitimate role. For example, we are talking about health today and the role of PPPs in universal health coverage. So the legitimacy of government gives them a seat around that partnership because it is in the interest and it's in the legislative and constitutional mandate of a government to deliver health or to deliver water or electricity or whatever intervention that the PPP might be looking at. So what is the primary role of the government is to provide the platform for legitimacy. That's one. Two, and I want to look at PPPs in a more expanded fashion because PPPs in health are a bit unique. And I know at the tail of the end of this discussion, we'll be looking at why PPPs fail or the challenges, and then more so the uniqueness within health. Because sometimes in health, we forget a fourth P, the people. When you bring the public, the private into a partnership and you don't incorporate the people, because in health, the primary recipient is neither of the two. It is the people who lie right in between that triangle. So the purpose of the public, if you may, looking at it as government here, is also to hold fort on behalf of the people themselves, because they might not sit at the table, yet they are the primary recipients. So I would say those are two key roles that the public puts forth. And then, of course, the third one is to provide the legal framework upon which all this happens. Because PPPs, if you take an example of the way we define them in the country, sometimes are too big in terms of like if it's infrastructural development, building a dam, building a road. But when you come to health, the P of the private, we want to expand it even to include an individual. So I look at them, that P, as a non-state actor of the private, of the public, private, sorry. So for the public, I think we are representing government here, and I think I would put them to those three major roles.
All right. Thank you, Dr. Kibacho. And we've now heard, what the private sector sees as its role in the public sector. And definitely taking note that probably we should be talking about PPPP, adding the people, because this is healthcare. And so, Faith, if you would tell us, from your experience across different markets, do you know of any good examples of PPPs in healthcare in developing and lower income economies?
Thank you, Fraser. So our overarching goal is to increase access to primary health care as it ties to universal health coverage, ensuring financial protection and improving quality of health services. And this can be done in different ways. So there's about 3 or 4 different typologies of PPPs in the African health sector. And that is determinant of the degree of risk in terms of private sector involvement. And then once again, also the degree of private sector involvement. So there's PPPs that have to do with resource sharing, which have a low degree of private sector risk and also a low degree of private sector involvement. And these remains probably the sharing of staff, medicine, supplies, and inputs. This is where we talk about pooled procurement and so on. These relationships are more so ad hoc, informal, and scalability is kind of iffy. Then we go to the second tier where we're talking about contracts, MOUs, leases, and concessions. And when we talk about leases and concessions, we're talking about leasing facilities, existing infrastructure, and not building new facilities. So public sector actually engaging private sector to actually embark on existing facilities and running them. We're talking about medical equipment service agreements. So instead of procuring, we're now looking at contracting for services. And I'll give examples of that. There's equipment maintenance that actually goes into managed equipment services. In contracting, we're talking about contracting of services and so on. Nowadays, we see things like housekeeping, dietary, don't necessarily have to be something that public sector is embarking on. We can actually get services outsourced. Facility management, South Africa is a very good example where facilities that exist are now managed by private sector, as well as ancillary services. So we see that these leases, contracts, MOUs, and so on are more so formal, they're contract-based, scalable, and typically yield the greatest health impact when we're looking at the various types of agreements. And then there's the third one, which has to do with infrastructure, where Dr. Obita talked about design, build, and operate. Typically, we're talking about infrastructure here, but what we see is that there's a high degree of private sector risk, and then there's also a high degree of private sector involvement. It's capital intensive, complicated contracts, limited MOH skills to design and implement. So not that they're not doable, but a little bit more complex to implement. I'll give you an example as Philips has engaged in Kenya with community life centers in Kiambu, Mandera, and Makueni. Typical infrastructure sort of build, operate, design, build, operate, where they're enhancing infrastructure, equipping facilities with equipment, upgrading the infrastructure, building reliable or implementing reliable sources of energy, water, and so on. And then also utilizing remote monitoring to actually monitor the equipment and so on, because we know maintenance of equipment is always an issue. Very innovative, scalability, sort of hard because we're also trying to find out or figure out the business model that works as it ties to working in the different counties. When we talk about Farm Access Foundation, the organization that I represent, we actually use technology as a platform and have been contracted by some of these pilot counties, Kisumu County and so on, to actually enroll citizens into the UHC platform, but also through a mobile wallet are able to ring-fence funds for health, similar to savings for NHIF and so on and so forth. When we talk about management equipment services, GE is a typical example where we have deployed a service contract with counties where equipment is being deployed to health facilities, but then long-term a maintenance plan or a maintenance agreement to make sure equipment is there and functional is actually core to that agreement. Most pharmaceutical procurement is through contracting with local manufacturers, which has a direct impact on quality, cost, as well as local job creation. Another example that I think is really, really interesting comes out of Rwanda, the company Zipline, where they're using drone technology. So now we're not just talking simple. We're actually moving towards the innovation space in terms of using drone technology to transport blood and essential supplies to the last mile. We've seen this impact maternal mortality rates significantly. So very, very innovative. AMREF, developing innovative e-learning platforms to build local capacity with health workers in partnership with the Nursing Council of Kenya, for example. South Africa, I mentioned, is a good example where public facilities have outsourced management of service delivery to private sector. And what we see is this reoccurring theme where scalability in PPPs is more highlighted in terms of contracting services and outsourcing to private sector to allow for ministries of health to focus on their core functions.
All right, thank you, Faith. And I think you've given quite a wide array of examples that we could actually, look at in terms of successful PPPs. But one thing you've mentioned is the longevity of actually seeing the outcomes, as well as the fact that the scalability is still questionable. And so for me, I would ask, from a private sector perspective, where really every investment has to have a return, to Dr. Walter, what motivates the private sector to get involved in PPPs, especially in health system strengthening, where the outcomes are not immediate? And yet, for example, especially when you talk about the private sector where you have, shareholding, or even where the financial return is a real issue, why would the private sector bother to get involved in PPPs, and yet they are quite intensive in terms of capital?
All right. I think first it's important to categorize the private sector players, because when we talk of private sector, you have not-for-profit players, you have faith-based organizations, and then you have commercial, full commercial private sector players. So each of these have different incentives as to why they want to get into PPPs. When you look at the non-commercial players, for example, the not-for-profit and the faith-based, their incentives are more on social impact. What is it that they're going to do with the public sector to touch many lives, to change, to reduce suffering, to reduce disease? Those are the social impact is one of their main incentives. When you come to fully commercial organizations, the bottom line is, how do they create value for money? For every dollar that they're putting in, how is their value? And looking at different players in the commercial sector. So I'll take, for example, in the supply chain, you would have people coming into PPPs in order to have volume distribution of particular products and supplies. By having volumes being produced by a contracting mechanism with the government, then you're able to get economies of scale, and you're able to even reduce the cost of these medicines. As you reduce these costs, and the manufacturer is guaranteed of volumes, he's also still able to get his or her profit margin that can be able to sustain the business. When you look at other PPPs, developing efficiencies within the system is another incentive that drives both commercial and NGO or faith-based organizations. What do I mean by efficiency? So if you're able to reduce the amount of wastage in using a PPP, then you're able to get more health with the same amount of money, and not necessarily putting in more money to get the same amount of health. And if you're able to get these incentives aligned with the PPPs, adding on to that is the incentive of having proper regulation of both services and commodities and supplies within the private sector. You find that when PPPs are strengthened, you end up having an increased regulatory framework that cuts out or brings out people who do not either comply or are bringing in irregular practices or goods or commodities. So by doing that, you end up having both government playing its role of regulation, as well as private sector doing its own self-regulation. So you end up having less commodities that are fraudulently brought into the country. You have less service delivery that is provided by either unethical practices or untrained staff within the sector.
All right, thank you, Dr. Walter. So you're talking about, it's not just about the money. There is more that goes into, what benefits the private sector, which is about impact. It's about the market and the friendliness of the market to actually bring in their products and all the other issues that you've mentioned. And so for private sector now, we have a view of what success looks like and why you would invest in PPPs. But for Dr. Kibacho, why PPPs? why not just follow the traditional donor-funded mechanisms or debt from, the World Bank or IMF? Why get into PPPs? And, what does impact of how do you define the success of a PPP beyond just the structuring and maybe, having a proper legal framework? Because a lot of questions have been asked, so what after the partnerships? What does the government actually look at as a successful, impactful outcome for PPPs in UHC, through strengthening of the health system?
Wow, those are many questions in one. I will attempt to answer most of the ones I can't remember. I'm happy that Dr. Walter has alluded to some of them when he was talking about the private side of things, and it was good that he classified them in terms of those that are focused more on the social impact and those that are a bit purely business, because when you're looking at measuring them, then you have to be looking at them from that perspective of what was the initial intention. And let me say right from the beginning that not all things in health can be done with PPPs, So when you understand it from that perspective, there are things which are easier to do with PPPs. There are things, especially because health leans so much on in offering a service, and that's one. And then two, there are a lot of things that are public good. For example, the government is not in the business of making profit, if you may use that word from the bare meaning from business perspective, that there are some services that we offer. The return on investment, when you look at it on the surface, might not be visible, but when you look at it in economic terms, take an example of, let me use roads, for example. Sometimes it's very difficult to judge the value of a road until you start looking at the benefits beyond just vehicles moving on them. The same thing with health. It's very difficult to judge a program by just counting the quantitative part of it. If you are doing, let's say, the managed equipment service, it's very simplistic to just measure its success by just looking at the number of x-rays that were done, the number of people who were put on treatment. You have to look at impact, and not only in the near future, but also in the long term. People's livelihoods were improved. There were efficiencies. There were deaths that were, lives that were saved, premature mortality was reduced, suffering was reduced. So those are qualitative. So what I'm alluding to is that from a government perspective, we look at these successes, measuring them both as a qualitative aspect and also as quantitative aspects. Let me look at a few things that we look at, depending on the intervention, because it would be difficult to, somebody needs to mute their mic. Right.
Okay, thank you, Doc. And I think, it's clear that,
1 minute,
sorry, please go ahead.
Yeah, I just needed somebody to mute the mic. There was a lot of noise in the background. Beautiful.
Oh, sorry about that.
No, it's all right. So if you look at the successes of a partnership, of course, it stems out from the intervention's goals or what you intended to do initially. Daktari has alluded to things like efficiencies, things like satisfaction. We measure how much are people satisfied, and that's a qualitative aspect. How much scalable is this? How much savings have we done? And from government side, we ask a simple question. How much were we using to deliver this kind of health in terms of how much more health were we able to buy using the same coin? Of course, health indicators is usually our simplest thing to run to. This was the number of mortalities. This is the number of mortalities after the program. Sometimes looks very simplistic because initially, in the short term, these indicators don't change. Some of these indicators don't change very rapidly. It's usually a result of long-term investment. Of course, a lot of PPPs within health also build the capacity. So you could be able to have an independent person look at the capacity and review it and tell you whether we are succeeding or not. There are methods that are coming up now that are qualitative and quantitative, and they are objective in measuring, because it's not just a matter of saying, oh, it succeeded or it didn't succeed. So majorly, I must say, the incentive of government going into a partnership is purely mostly because they have a legitimate role and you want to do things in a more efficient way. It's about buying more health using the same. And remember, in economics, resources are finite. Governments don't have all the money to do. And again, in the process of you partnering, you're also sparring business and creating employment and providing a platform for the private sector to participate, be it in civic duty, be it in the private sector also has a human side. You know, usually when we look at PPPs, people look at, like, in the past, and things have changed. In the past, the form of partnership was, oh, you're the private sector, give us your money, let's throw it at a problem. And that was not sustainable. Now you come in with a win-win. You have objectives as the private sector, we have objectives as public or the government sector, and there is a way in which that can work when all have put their cards on the table and have a win-win and one target towards the partnership. So I would say that's the incentive that government goes into partnership with.
All right, thank you so much, Daktari. And before we go to the audience for questions, I want to just throw a spanner in the works. And, you know, what I've heard from our guests is all good news and there's really a case for PPPs. So my question is, in April, you know, there's been a lot of talk around PPPs, even as we are moving to UHC by 2030. There's an article, you know, that, you know, was published in April this year saying that, you know, public-private partnerships don't work. It's time for the World Bank to take action. Another, you know, article was mentioning that, you know, PPPs are a double-edged sword. Others say that PPPs actually interfere with market forces because suddenly you're selecting a particular partner to do some, you know, huge amount of work, yet there are other people who could probably, if given a chance, have done the job maybe better for cheaper. So the question is, you know, how do we respond to this, you know, kind of, you know, critique towards PPPs? And do we even have enough data to prove that actually PPPs work? And, you know, as our guests today, what are your thoughts to this kind of critique and, you know, some questions around whether we should actually go the PPP way or go back to the drawing board?
Well, I can respond. Let me start by responding to the question on do PPPs work? I'll reference what Dr. Kibasho just said. PPPs are not the same silver bullet to all the situations you need in healthcare. When you're thinking of PPPs, yes, there are those that succeed and there are those that would fail. However, before you get into a PPP, there are a number of things that you need to be aware about. One, in PPPs, you require new and different capacities to manage effectively and ensure there's value for money. So when thinking of a PPP, there are some that will ensure value for money and there are those that will not. So that's one thing to be thinking about. Secondly is, if it's not structured well and if it's not monitored well, then there are costs that can move to the consumer, the fourth P that Dr. Kibacho is talking about, the people. So you can end up having a PPP that if it's not structured well, you'll end up having the same service or the same product being delivered to the consumers at a higher cost. Another thing that PPPs hinge on that we don't talk about much is the political side. You need political stability to be able to support and implement any PPP in health. If you have changes in political alignments or political stabilities within a country, then again, these will lead to difficulties in implementing PPPs. And again, you also think of the financial stability, both of the country and of the private party that is coming in to implement the PPP in health. So there are quite a number of risks to talk about, and I'll let also Faith mention a couple at this juncture.
I think it's very crucial to actually look at our current ecosystem in a lot of lower middle income countries, and just to understand that the ecosystem is very dynamic. So it's very important how we organize ourselves. Now, from a national level, we have national policies that are being enacted and so on and so forth. It takes quite a bit of time. And then when you come down, let's say from a Kenya perspective to the county level, you see a lot of counties implementing different models that really probably have not aligned with the national policy. So how are we looking at our current environment and enabling counties to take a lead and run with it, so that we're not waiting, but we're actually having it fit under the national structure. So there's some coordination that has to happen. So it doesn't seem one county is doing something that is contrary to another. The other thing is that once we sign these contracts, you don't run. And truly, when we're talking about PPP and having a centralized unit at the national level, government still retains responsibility for ensuring access to and quality of services and products. So we don't sign and run. So there's this need for ongoing government engagement. And with that ongoing government engagement, there's capacity building on the Ministry of Health side to make sure these projects are managed efficiently and effectively and getting value for money and getting the desired effect and outcomes. The second one, it's difficult to plan for all contingencies that may arise. It's a new area. We don't know, we can learn from evidence-based practice, but it's still new to our local context. So planning around contingencies or difficult to plan for all contingencies that may arise over the life of the PPP. And then we are in a lower middle income country and we don't like to talk about the elephant in the room, but when we invest into certain projects, there's the issue around lack of transparency or corruption. And so building transparency around all the areas that have to do with managing these contracts and relationships has to be forthright and upcoming.
Thank you, Doc. Dr. Kibacho, what do you think? PPPs, yes or no?
It's really not a yes or no question, Frazier. The question is, what metric are you using? Because failure is relative. And by the time you're entering into judging the success of course, there are PPPs that fail terribly. But the failure of one PPP does not generalize that PPPs don't work. As you've heard Faith saying, it's now that we are starting to get a sizable amount of evidence to judge some of these PPPs. So I would think it's premature to use the few or a few. Out of one that you see, there are many, many others that probably are not documented. Because usually people look at PPPs that were published, and there's a bias in there sometimes, because if you are only confining yourself to judging PPPs that have been published, then there's a skew towards PPPs that are critiqued or challenged. So I would encourage that we broaden the denominator, if you may, of PPPs, because there are many that have not published. Now, let me just speak a little about it being a double-edged sword and, we should move away and let the World Bank do this. The question I ask in a more naive way is, well, for sure, there could be a double-edged sword like any other program, but who wages the sword or who's holding this sword? I mean, from what perspective are you looking at them? Because as I gave the example of government, sometimes most of the things that we seed into PPPs are public goods, and public goods are very difficult to judge in terms of success. You know, if you are judging, let's say, Thika Road, most of you, if you are from Kenya, you would know Thika Road is a thing you can see. You can say, oh, it's successful. It was a road. It was supposed to be 5 lanes. It is 5 lanes. There are more accidents. You can judge. But if you're partnering to improve, let's say, livelihoods or to improve services in the hospital, yes, they can be judged, the physical part of it. But as I said, the impact, the improved livelihoods is a very qualitative aspect. And sometimes the metric that we use to judge them sometimes doesn't do these things very, don't favor them. Now, sometimes some of the interventions take long to yield results. As Faith has said, that this is a new concept. I'm surprised that, and some of the indicators are long-term. Political capital sometimes is very important, and sometimes we underestimate the value of political capital in some of these PPPs. Take an example of the UHC. It's being implemented midway between the current government. this is an initiative that is not to run for 3-4 years. It's not a start-stop. It's a thing that will transcend the current government. So when the new government comes in, two things could happen. It's an easy target to use to challenge the previous government, or it's a thing that you would pick on and ride on and say, oh my, this is a problem, it's a challenge, it's not working very well, we can improve it. So politically, goodwill is very important. It could kill or make a PPP. And of course, it's a matter of impression. If one person says, oh, this thing failed, this is not a good thing, it creates an impression, and that impression at the public domain, then the judges are out that it has failed or it has succeeded. So I would say there are methods now that are more objective in terms of judging PPPs, and they have been checked around. They are more objective. It's not like innuendo where a politician stands and says that was a scam. There are better ways. And of course, when things are judged in the public arena, they sometimes take a different angle, which probably is not very objective. Finally, I may say that whenever we are doing these PPPs, it's a competitive process. And you will also realize that people who are edged out definitely may be aggrieved and may not be very fair to the ones who got to be in the consortia. And we usually encourage consortia. It's easier to deal with a group of people because no one person has the capacity or the monopoly to deliver. Health is very unique. Health is not just, it's not like we're just building a dam. Somebody can have the technology around building dams from A to Z. But in health, you require a lot of skills to deliver one package. So you require to, even within the PPP, the P part of the private, to partner with other people to deliver in the form of a consortia, because no one has monopoly to deliver some of these things. So we usually encourage more consortia. We usually do a competitive process, but as it were, there has to be frameworks. And as I said, if you look at the PPP Act that we have in our country, it is developed. There's only one country, by the way, which has a legal framework of looking at health partnerships for development. So most of the other countries use their PPP frameworks that were not written with health in mind. Health tries to warp itself around those acts or those regulations, which probably were meant for structural, infrastructural, big projects. But I think within health, we have now a sizable amount of case studies that we can use to direct. But as I would say, I think we need a proper legal framework to help understanding PPPs within health.
All right, thank you, Dr. Kibacho, Dr. Walter, and Faith. And I think we've covered a lot of ground. And even as we now, look at the questions that we have from our audience, the issue of data evidence still remains, one that we need to answer and see how best to move forward. Because unless we have evidence to show what works and what doesn't, then we'll never really know how to structure, whether it's the legal frameworks or the implementation frameworks of PPPs. And I can see, we also have from the audience a question around, the lessons that have been learned, where PPPs have worked. And so I think I'll open this one to the panelists and ask, what lessons have been learned, at least maybe top 2 from the PPPs have worked in healthcare. And basically that would form some sort of best practice for us moving forward as we all are working towards UHC. So maybe Faith, you can start us off.
So I think one of the things that we were saying in generating PPPs, what is central and core is government commitment, and then also government capacity in the different areas to manage that relationship. So it comes from identifying the gaps, it comes to contracting, and then it comes to monitoring and evaluating the desired outcomes, and then ensuring that there's value for money in terms of we're paying for what we said would be delivered. So government is central to actually actualizing them in working and play a key responsibility. Yeah.
Yeah, and just to add on to that, and to emphasize that, you have to have both the political and the government's commitment to be able to see the PPP through. And the PPP contract that is entered should also live beyond a political cycle, so that if you have one government coming in after the current one, that PPP can be able to survive and the new government doesn't kill it. That is one. Two is in the contracting of the PPP, the nature of the contract. It needs to have a win-win scenario, so that the private entity coming in to establish the PPP is not the only winner and the government is the loser. We have examples across Africa where PPPs are entered into, and midway in the PPP, you have the private sector player taking over that whole industry in that country. So that's a win-lose kind of scenario. And in the contracting, it needs to have a win-win scenario. Those are the bigger things I would look at. And then beyond that, now you see how the financing structure is put in place, how the transfer of either the assets or the service delivery is going to be done beyond the scope of the PPP. Because in some cases, you find some PPPs fail because you'll find the private entity building, operating it, and at the point of transfer, the public system is not able to manage or sustain that business, and it goes down. So those are some of the top things I would add.
Dr.
I think I'll add one more, and that has to do with visibility. And so this is where development partners and innovators come in. I think we lack a platform where innovations are visible, so that ministries of health can actually see what's working, what's not working, actually have an objective environment where they can assess things that are locally conducive to their settings, so as to make appropriate decisions on what programs they want to engage with or not. So there's a visibility issue where there's a lot of innovation and iteration that's happening within the private sector that can be taken up to scale by ministries of health, but they have to have that information in terms of what's happening in their local context, who is trying things that they would actually want to take on, and so on. So a platform for visibility as well.
Dr. Kibacho, as we take your comments on that, I'll also add a few, probably two more questions to this one. And one is that one of our, listeners is talking about the fact that, feasibility studies need to be done with a clear exit clause, especially for the private sector, which has rightfully been mentioned by Dr. Walter. But also there's a question about whether the indicators used to assess the impact of PPPs are objective, especially when it relates to access to healthcare. And I think you touched a bit on that, and maybe you should probably even give us an example of how the government of Kenya has actually, carried out some objective impact assessments.
All right, thank you for that question. In case I disappear on that screen, I'll be taking it on my phone. Now, it's good that Daktari has talked about there being a win-win, and that lies the success or the backbone of the success of a PPP. There is the private entity succeeded and the government failed. A PPP fails in total. A PPP is a partnership. And when people don't understand that, then the same private sector cannot point at government, or the government cannot point at the private entity and say, oh my, you failed us. It's a partnership. So one of the key structures that make partnerships succeed is putting all the cards on the table. Sometimes you find people entering into a PPP and there are few cards under the table that are a lush you know, halfway when we find ourselves in courts or something, and you wonder, why wouldn't we have unearthed all these things at the point of conceptualization? Daktari is the one who talked about there being no rush. We need to, first of all, I'd rather we spend 90% of the time planning and 10% of the time implementing rather than the other way around. Because sometimes people are quick, oh, we have secured a partnership with government, so we are quick, let's just jump in before we are thrown out. And then the problem comes later in the implementation. So I would, now, as I said, there is enough of these partnerships within health that have informed us of the how, where we have burnt our fingers, where we think would have done better. And of course, sometimes the indicators, you've asked a question about indicators. The M&E framework needs to be thought about during conceptualization. Sometimes you find that it is during the project is when we start thinking, oh my, what about these indicators? So the M&E framework needs to be inculcated into the project right from the beginning. M&E is a core because that's what you'll use to judge yourself. That's one. And then two, it has to fit within the existing structures of governance. For example, reporting on indicators of health should be done through HMIS, because you're building, you're not reinventing the wheels. And sometimes, especially issues of data, there's usually a lot of jitters around ownership of information. One of the premises is usually that the primary custodian of patient and health information is the government. So sometimes when the public, the private comes in, and I understand this, because of wanting to have a sense of exclusivity. Sometimes it looks like the government is too big, it is swallow us, we can't be seen, or there's no visibility. And some of these concerns usually come because maybe people didn't sit down well and understand what's our role. And usually it's a small river that joins the big river. Of course, the big river will look like it's swallowing the small river, but there is a role of sharing of the information. But remember, the government has a legitimate role of being a custodian, protecting the patients, and also having other roles in terms of data. One of the things that also is forgotten, and it's a question you've raised, is that we don't think of sustainability at the beginning. We come to think about it, oh, this project is closing out, or it's 1 year, 2, or we're in the consolidation phase now, is when we start thinking now, who will pick on this? Will the government be able to absorb it? And so I think we now know, we have learned that sometimes maybe we don't spend so much time planning out the whole thing. From the beginning of the project, you should be able to see the end. You should be able to see the transition. You should be able to see who picks on this from here, and where will the resources come from, and how does the private individual transition and exit. Those things should have been thought earlier, so that you avoid issues of where people are quarreling in court, or they are jitters, because they don't do well for other partnerships. They start tainting the image of PPPs. Because if all of them are ending up in the courts, or they're ending up with people throwing their hands, it does not work better for the other one. And the final thing that I would say is that we have always to remember that health is a very unique public good. In these times, of course, health has to be looked as a good or a service that can be subjected to principles of economics, because you have to be able to tangibly measure. In the past, health used to be taken like, oh my, you can't measure this thing. Let's just give guys vaccines or distribute nets and we hope that it works. No, now we are able to measure either qualitatively or quantitatively the success and the failures, and correct it along the way and look at the return on investment. And you can even be able to say which is the best option given many options. So I think that question was very pointed to one of the participants, and I think I hope I've been able to answer it rather than run away from it.
All right. Thank you so much, panelists. And I think as we conclude, I just want to ask one last question that also has come up from our attendees, and it's a question of equity. UHC is really built around ensuring that everybody, everywhere, has access to quality health services, be it promotive, preventive, curative, palliative, rehabilitative, name it. So how do we structure PPPs to actually achieve equity? Because remember, at the end of it all, you talked about a win-win. How do I convince the private sector, especially for profit, that the bottom of the pyramid, in terms of the population, should actually be considered when structuring PPPs? And I think I'll take that from the panelists and then start our concluding remarks. So Faith, thank you.
I think from some of the examples that I alluded to, you have Philips, which is a multinational organization that is a for-profit and commercial organization that has taken the risk and sort of the moral aptitude to actually have a social mission. And so as we are, the other one that I mentioned was Zipline in Rwanda, who has contracted the Rwandese government to be able to use drone technologies to transport medications, blood to the last mile. This is very rural areas. I'll talk about an organization that I worked for that was building a social enterprise, building maternal and child health facilities in emerging settings as well. There's a balance, but I think you're seeing a lot of corporate responsibility in how for-profits are approaching their impact, and that is changing. And when we talk about for-profit, I'd like to just sort of steer away from terminologies that scare people away and sort of move to softer ways of nomenclatures, such as non-state actors who actually want to drive impact, but as they're contracting with governments, they know that the return on investment might not be immediate, but it's planned for in that contractual obligation. So we know we might not get a profit right now, and the profit really is to invest in the business and also reach more people. That truly is when you see what how they're applying themselves, it's to reinvest in the business so as to have a greater impact. So I think it's tied to the contractual obligation and also being realistic about return on investment, which might not be immediate, but it's actually factored into that contract.
All right, Walter, what do you think? Equity.
Well, when I think of equity and private sector and PPPs, people tend to focus more on the underserved, and sometimes by focusing on the underserved, you lose equity because the served are also lost in this. So the whole idea is actually at the contracting phase. I would think about it from the conceptual framework, the contracting phase. You think about the intervention that we do want to have procured through a PPP. Do the people, the consumers, irrespective of age, sex, socioeconomic standing, get access to the product or the service that is being procured through the PPP? And just to lay emphasis again, it is all about the stage of conceptualization. What is it that we want to procure through a PPP? Getting a structured way of having that contracted with a win-win scenario for all the players, and having that monitored and evaluated at various stages of its execution. So that if at all there are any stages that inequality or inequity is picked up, it's addressed and nipped at the bud without it necessarily being upon in the flesh as you proceed with the PPP.
All right, Doc Kibacho, tell us.
Thank you. And I can't agree more with the two previous presenters, and they put it very well that Walter has talked about our focus sometimes is wrong when you focus on the underserved or the guys below the pyramid, or, you know, way down there, the poor billion. Sometimes equity is not served just because that guy has gotten the drug. No, it's broader than that. And I look at it from the perspective of the fourth P. We measure equity from the person's perspective, the people's perspective in a PPP, because the P of the public and the private might have been very beautiful. We have a project that has really worked from the perspective of the government or from the perspective of the private equity fund or whoever is injecting money. But do the people being served, are they satisfied? I mean, if they have not been, that fourth P is not been met, then the success in terms of equity has not been met. That's one. Two, of course, when you look at UHC, one of the goals is to shelter or to shield the common mwananchi from catastrophic costs that come with accessing health. So that's also another measure that you can look at, because even a rich fella can also have a catastrophic cost depending on the input that he has put into the healthcare. And then, of course, there is issues of allocative efficiencies and the obligations of government. It is in the interest of government to serve its people. So when the private sector is looking at how much return on investment in terms of money, because at one point they have to make a profit. Sometimes when you're talking about PPPs, I usually encourage the private not to come with the face of, oh, we are not here for the money. Oh, yes, they are. I mean, they have to make a profit for them to be there tomorrow. And it's not a secret. That's what I mean by putting the cards on the table. And on the government, so profits are not really the thing. It's about efficiencies and delivering the core mandate of government at a less cost or at a more efficient cost, and also spurring economic growth by partnering with the private and also giving them a platform to participate in nation building. So I would say issues about equity, you have to look at them with broader eyes. If you look at the issue of poverty and health, poverty.
All right, I think we've lost Dr. there, but I think thank you so much to the panelists for this conversation. And I think I'm sold to calling it public-private partnership people. Over to you, Dr. Nyagero.
Thank you so much, all of us who have participated as the guest speakers and also as participants. We are very, very delighted. Our rapporteurs will be able to finalize the report, and it will be able to be prepared and presented online. And I'm also now taking this opportunity to welcome you to our fourth and last webinar in this series, which is going to be held on February 11th, 2019. And please, I'm requesting each one of us to save the date for this last webinar as we move to the conference. The title of the webinar shall be, Has Technology Improved the Delivery of Healthcare in Africa? The Case of Telemedicine, E-Health, and M-Health. We are looking forward to meeting you then. Happy Christmas, and have a Merry Christmas and a Happy New Year, 2019.
Thank you.
Thank you.
Okay. Thank you, everyone, and bye.